So welcome back, everyone, and welcome to Climb, Kathy, Thea, and Travis. It's a pleasure having you today. Thank you for taking the time to be with us. So before we jump right into it, because we've got a lot to talk about here today, we're going to be talking about chronic care and disease state management. Specifically, we're going to dive into diabetic self-management training. We'll start with that one. Then we'll talk about overall wellness management, weight loss, smoking cessation. Then we'll get into clinical workflow and how to implement a program like this. And we'll bring it all together with clinical collaboration. So before we dive right into that, because we have a lot to cover here in about 45 minutes, I'd like to go around, starting with you, Kathy. Just tell us a little bit about your area of specialty within this discussion today, and anything else you want to add, and then we'll just kind of have each one of you introduce yourself with a little more detail. So,
Sure,
Kathy?
I'm Dr. Sure. Thanks for having me today. I'm Dr. Kathy Campbell. I'm a clinical retail pharmacist in Owasso, Oklahoma, which is just north of Tulsa. I've been practicing pharmacist in my town for 30 years. That means I have 4 generations of families that I've had the privilege to study and serve. So basically, I'm here to represent the weight loss component, but there's something very fundamental underneath that. Weight is a symptom of underlying health. And it became very clear to me over the last 30 years that medications weren't providing the level of health and function I wanted for these friends of mine that I've been serving for 30 years. So really, I do what I call foundational health. I help people prevent the onset and delay of disease. And weight management is one way that people can engage in that conversation. And so I've been doing weight management for about 6 years now, but really the impact of health and wellness is what I'm really up to.
Okay, great. Thank you with that. Thea?
Hi, thanks for having me. I'm Thea Blystone, PharmMD. I am a little bit different than Kathy. I have a consulting business doing pharmacy consulting services, and I really am pretty much on chronic care management and that between office visit care that I think pharmacies can really implement into their programs and into their workflow pretty quickly and easily. So that's where I am, that kind of along with Kathy comes along with wellness, right? You're talking about lifestyle, you're talking about diabetes, you're talking about wellness and smoking cessation and those things. So I think overall chronic care management is definitely a great step for most pharmacies to explore and dive into.
And Travis?
Thank you. I'm a pharmacist and I'm a pharmacy owner. I've got a few stores in Oklahoma. I'm board certified in ambulatory care pharmacy, so I specialize in the chronic disease states also. And years ago, I began teaching pharmacists. I started with NCPA and a few other organizations on how to put these clinical programs into a traditional dispensing workflow. And a lot of that is, if we want to be providers, we have to look like providers. But when you walk into a pharmacy, a lot of times the pharmacist is still the one doing all the things. And so as I kind of went into that, I taught everyone the clinical things, how to put them in the workflow, but my results were pretty short-lived. And so, a number of things I tried, but the one that helped the most is I went and got certified in the psychology of leadership. And when I got certified from that in Cornell, it helped me learn that it's all about people. And so if you can teach pharmacists how to engage their people into that workflow to get these chronic disease state programs going, a part of that psychology of leadership is also the science of implementation. So you can use those steps and really make people really successful. And so in particularly today, I'm going to talk about diabetes self-management training. I've taught hundreds of pharmacies on how to become accredited and implement those programs. And I'm about to launch my next one through NCPA again. It's going to launch in June. So I'd love to tell you about that a little bit later as well.
Okay, great. So before we jump into the topic of diabetic self-management training, I already know what I'm telepathic here. I already know what some of these pharmacists that are listening are thinking, and they're thinking, I don't have time for this. I'm too busy. So, and is there any money in it? So I'm just going to briefly ask that question before we jump into this. Am I going to get paid? How does that work? Who would like to go first? How do you respond to that?
Well, Thea's made a whole business out of it. So Thea, you want to go first?
Sure. I think that there is definitely money in it. It may look different than pharmacy traditional billing for sure, but I think that there are plenty of revenue building things with the diabetes education and even, just bringing them in to talk to them on a monthly basis. You incentivize them to come back and make it look, make it worthwhile for them to come back into the pharmacy and see you. I think that is huge when we look at getting people to do what we need them to do for their own health, because sometimes they just can't see it. So yes, that's the long answer. Yes, there is money in it for sure. Plus it drives business for your pharmacy. So billing the codes plus then having actual foot traffic through the pharmacy is an amazing opportunity. Travis, I'm sure you have seen that a lot.
I've seen it a lot, and in fact, I'm going to call on Kathy next because Kathy often brags to me about how much of a percentage she is supported by non-dispensing revenue in her salary.
Yep.
Okay. Kathy, tell us more.
So I'm routinely 15 to 20% of my business is non-dispensing revenue and routinely have margins at 30%. And a lot of that is I had to first be willing to create something of value and second, ask patients to pay for it, right? So I have a cash-based model and, there's a lot of opportunity in people who don't want to be sick, right? And there are a lot of different industries that are currently making money doing that with not near the technical skills that a pharmacist does in our industry. There are people who are talking about chemistry who have almost very little actual knowledge or training in chemistry, right? Be it supplements. It's funny, one of the most powerful things you can do for your health is get the food right? And tomorrow I'll be dispensing organic vegetables from the pharmacy. I've already sold broccoli seed sprouts this morning. Why? Because that's the chemistry that makes a difference in physiology. And as a pharmacist, I'm completely convinced that it is the pharmacist that can help patients not need medications. And that's the business model that works. I mean, it is something that I think we're missing as pharmacists. We're very valuable, but we don't put any dollars on our time or our value. And I found I had to be willing to put a price tag on a product that was different than the one-trick pony of dispensing. And what I find is most people have no problem with that. If it's valuable and if it's marketed as such and you provide the value, cash is a very viable market. And then what interestingly happens is other people start seeing it valuable. Employers, possibly catastrophic insurers. And then this model starts expanding if you can keep people well. I'm convinced there's a huge untapped market, and I think pharmacists are perfectly suited for that.
Travis, did you want to add?
Yeah, and I would say, with my coaching organization, Farm Further, it's all about getting people in the right spot, and it's all about just low cost, really high leverage maneuvers. And, you can take something simple like medication therapy management, and, let's talk about a CMR where you're going to get paid roughly $40, right? People are going to say, MTM is a 4-letter word, and they're going to lose money on it. But the pharmacist is spending an hour and a half on that encounter. If you would have a technician do the med rec with the patient and have the right person in the right spot at a lower hourly rate, they're actually going to do a better job because they're going to ask Ms. Smith, tell me how you take your simvastatin, as opposed to saying, you take that simvastatin at bedtime, right, Mrs. Smith? Well, they spend the 20 minutes on the phone with the patient, and then the pharmacist hops on for 3 to 5 minutes at the end for the therapeutic decision making. Well, now you've made somewhere between $18 and $20 on a $40 encounter. Another example with diabetes self-management training, and I'm sure, Thea runs into this quite a bit, but people are very afraid of the appointment-based model in pharmacy. And you talk about, is it a profitable program? That's what you're asking, Brad. We tend to take walk-ins all the time, and we tend to end up with 5 different things going on all at one time in the community pharmacy. But if they would do the appointment-based model, they could block out 1 hour a day and serve a ton of patients on a variety of different activities because they know that they're out of the workflow for that. Diabetes education, you can make $560 an hour, if you do it right. Thea can show you how to make $120 an hour on CCM because you get paid $42 for 20 minutes. But if you're making a 20-minute phone call and you're spending an hour prepping, an hour afterwards, an hour during, you lost money during that. If you have your ducks in a row and you have one patient scheduled right after the other, you have an hour out of workflow and make double your salary right there. So I think it's all in about doing the math. We don't know how to calculate non-dispensing revenue. So we got to learn how to calculate that, and we got to learn how to budget our time so that we have those appointment-based models and we can put the right people on the right spot. And if we all work at the top of our license, then many of these programs are very profitable.
Okay, and this falls in line with stuff that we've been talking about on Climb for many, many months, a year and a half. Really, and I hear the same thing from our panelists all the time. Yes, it's profitable. It's scary because it's new. It's something you have to learn, some new things, some new processes more than maybe in a lot of cases new things, and use your expertise and get paid for your expertise. And I've heard, Kathy, a lot of different panelists have talked about cash-based model because I guess as pharmacists and pharmacy owners so used to the old model of fill and bill and not really getting paid for their expertise. So it's refreshing to hear this. And everybody that listens to Climb regularly is hearing this over and over from really the most successful pharmacies in the industry and the people that are really making a change in becoming more profitable and really helping their patients. And I think that's another thing I just wanted to comment. This was from last month's panelists also. Pharmacists taking the position of one of my jobs is to educate the patient, give them the information they need to make the best decision they can about their health. And then people will surprise you. They want to be healthy. So I love what the comments have been so far. This is, this falls right in line with the other things that I think people are hearing over and over from panelists. So thank you all. Well, let's just jump right into the very first topic that we had on the list today, which is diabetic self-management training. And Travis, you're the resident expert here today on this topic. So, what is involved, from the pharmacist's perspective? How do you go about obtaining accreditation? How long does it take? Some of that information.
Yeah, so, I think it's a really missed opportunity by a lot of people. I think there's a lot of misunderstanding about what's required in order to be able to bill for this service. And the thing that's so interesting to me is it's a paid-for service by Medicare. Most pharmacies, the majority of their patients are Medicare patients. And so it's, a lot of new services that you're going to try to figure out how to do. You have to actually get those patients in your door. But with things like diabetes self-management education or any other thing like CCM that Thea does, those patients are already your patients. They're already coming in your door, and there's an opportunity there for you to capitalize on and really improve their health and well-being, because you not only have a great effect on their dispensing of what they're taking, but you also can help with their behaviors. And that's what DSMT is all about, is learning how to affect behavior change with patients. And I'm excited to hear Kathy later because, I think pharmacists can be one of the most successful providers for DSMT because of the relationship that we have with our patients. We can really affect the behaviors that they have more so than someone they never met in a clinical office setting. And you ask about DSMT, how do you get set up? It actually just became a lot easier, and I'm excited about that. There are standards that you have to prove that you meet, and you basically put together an operations manual that shows that you meet those standards. I say it's become easier because they redo the standards every 5 years. And so the last cycle was from 2017 to 2022. And in the very beginning of this year, they launched their new standards, and now there are only 6. I actually got to serve on a committee to help reduce some of that clinical inertia that was required to take care of our patients. So we reevaluated all 10 standards and said, some of these really don't make a difference. It's just a barrier to become accredited, but it's really not making an impact on patients' lives. And so you meet those 6 standards now, and that's what my class with NCPA is about, is to teach people exactly what they need to show to document that they meet those standards. The great thing about it is most community pharmacies have got the things in place already to be accredited. They just don't have it documented appropriately. So I give them a turnkey document to show them how to document exactly what they need. Another misunderstanding with diabetes education is that you've got to be a CDE, which means you got to have 1,000 hours of education provided, and you got to take a hard test, and you got to pass the test. That's not true. You can be a CDE, and that's a certified diabetes educator. There's a new nomenclature that goes with that now. But with the DSMT program, you have to be a pharmacist, or you can be a registered nurse, or you can be a registered dietitian. You can be one of those 3 things. You don't have to have the certified diabetes educator accreditation. If you are one of those 3 things, then all you have to do is have 15 hours of continuing education that's diabetes related. Well, most of these professions, I know in my state, to be a pharmacist, you have to do 15 hours of education every year anyway to be able to apply for a pharmacist license renewal. So what if all 15 hours just happen to be diabetes related? Then I killed 2 birds with 1 stone, and I can meet that requirement. So you get those 6 standards, in line, and then you prove that you meet those. And then basically you got to see 1 patient to show how you can take them through the curriculum that you've chosen to use. And so it's very easy to get set up. You will get accredited through either AADE, which is now called ADCES, they've rebranded, or ADA, the American Diabetes Association, either one of them 2. And those are the 2 bodies that will recognize your accreditation for Medicare so that you can bill to Medicare. You asked a little bit about what was required of it. Every Medicare patient who's diabetic gets 10 hours of education right off the bat. And it doesn't matter if they've been a diabetic for 40 years or if they just got diagnosed yesterday. They all get 10 hours. And so if someone was diagnosed 20 years ago and they've never had diabetes education, which they usually haven't, they still have those 10 hours sitting out there eligible. One of those 10 hours is a one-on-one, and it is payable at around $120 an hour. And depending on your MAC and where you're at with Medicare, it'll be a bit kind of a range of 110 to 134, I think is the highest I've seen. The group education is going to be about $28 for an hour per person, but you can have up to 20 people in class. So $28 times 20 people that's where I'm getting my $560 an hour. And so the other thing that I think people misunderstand is they think they have to have a big conference room. I got to have a big fancy space to put these people in to teach them. But you can set up some folding chairs in the lobby of your pharmacy to teach them, and it actually is a great marketing tool. People walk in and pick up their prescriptions, and they want to know who Kathy's talking to over there, and why are they getting this special one-on-one time with her? And then Thea says, oh, well, she's teaching diabetes education. And, you're diabetic. Would you like to get in on that? Well, yeah, let me get a referral from your doctor from you. And it grows your class with a couple of folding chairs. You can buy those for $10, So it doesn't have to be this hard, illustrious thing. And I think people make it that way. I'll stop there and pause, see if you have any questions or any follow-up.
So I guess one of my questions from that would be, how do you approach bringing patients into the program? Is you just reach out to all of, do you just reach out to all of your diabetic patients just from the beginning? And then
yeah, very good question. Go ahead.
So do they, do you have much pushback, or what would you say your success rate as you reach out to these patients is?
Yeah, so a couple of big points here. We always when we get accredited, people always want to go search for these new patients. They want to go tell all the doctors in town that we're accredited and you can send all your patients to us. Well, you actually have two battles instead of one there, because you have to change the traffic patterns of patients who are not yours already to come to your pharmacy. And in the very beginning, that's pretty difficult, because even if you get the referral from the doctor, when you call the patient, if I say, hey, Brad, this is Travis from MedWorld Pharmacy, and you say, I don't go to MedWorld Pharmacy, I go to Kathy's pharmacy. I don't know why the heck you're calling me, and you're liable to hang up on me, you know? So if I'm going to call someone, I'm going to say, I'm with the MedWorld Diabetes Education Center. I'm not going to say I'm with the pharmacy, because I'm not trying to solicit their prescriptions at that time. I'm trying to come educate them as a diabetic. And then they're going to fall in love with my staff and the service that they get, and I'm going to get their prescriptions later anyway. So that's not really why I'm calling them in the beginning. I'm calling to make sure that I can make them healthier. But, I think going back to your original question, these patients are already coming into our pharmacy, and they're our current patients. So your first step should be identify every diabetic that you have coming under your roof. The American Diabetes Association actually has 4 different times where you can really help someone benefit from diabetes education. And that's where I focus a lot of our recruitment on. One of those times is complications. And people think that they don't see complications. But I tell you what, if you see someone have a gabapentin dose changed, their nerve pain might be greater because their blood sugar is unmanaged. If you see someone get Lyrica added on and get changed off of gabapentin, their nerve pain might be worse. If they have a different eye drop added on, their vision changes might be due to unmanaged blood sugar. If they get a new diabetes medication added, if they have a dose change on diabetes medication, if they're not picking up their metformin on time, they're having a side effect, a complication. There are so many complications that we see every day in our day-to-day actions, and it's about training all of your staff to catch those. So if a star rating drug is not getting picked up at the window, that patient does not leave my pharmacy without talking to a pharmacist, even if it's a high school clerk checking them out. And we have a conversation with them. Another really big one is transitions of care. That's one of the other 4 that they talk about. Transitions of care is a really missed opportunity. We think about the big fancy transitions of care that Thea probably does, where you're billing the med rec they go home from the doctor, and we're seeing our complicated patients in 7 days and our uncomplicated patients in 14 days. Well, transition of care can be lots of things. What if you have an 18-year-old kid who graduated high school and is leaving mom and dad to go work in a manufacturing plant in another state, or going to college, or going to trade school? Now, someone who has had their completely managed diet and someone doing all the grocery shopping for them is not going to be living with them any longer. And knowing how to manage the complications is going to be gone. That is a transition in their care. What about a 64-year-old adult who has been working their whole life and has a great commercial insurance company, who's going to retire and go on Medicare? The type of test strips that they use for the Medicare plan that they choose is going to be different. The type of diabetes drugs they take is going to be different. Maybe they were on Lantus and now they're going to have to go on Levemir because it's not on the formulary. That is a transition of care that we miss out on. It's an opportunity to really help them. What about a new patient who moved to you from a different town? They got to find a new doctor. They got to find a grocery store. They got to find all these other resources. That is a transition of care. So you say, do we find, people, kind of giving us resistance? We really don't find that, because we're finding the right opportunities to help them. If you've got someone that's only on metformin and never really has any complications, they're not going to benefit from the service anyway. You're not looking to just go build a service and try to get dollars in your bank account. We want them to have an improved A1C. We want them to have an improved quality of life. And we want them to go tell everybody else about it. So that then they're getting us new patients to say, wow, they really made this an impact. The other big thing that you see in diabetes education, if they've ever been to one of the strict hospital classes, they've been told, don't eat this, don't eat that, never do that, always do this. We customize it and we say, Brad, tell me what you like to eat, and I'll tell you how much you can eat of it and what you can or cannot eat with it. I got a lady who eats chocolate cake every single day, and she told me on her first session, I'm going to eat chocolate cake every single day. Her last A1C was 5.2 because we showed her the portion of cake that she could eat, and we said, when you have your cake, you can't have your dinner roll, and you can only have half as many mashed potatoes as you usually eat. And just doing that alone, she eats a chocolate cake every day, and her A1C is managed, and her doctor can't believe it's not butter. So I think customizing it to the patient, empathy will go so much farther than competency, and that's where we get really stuck. Pharmacists really get stuck on the competency.
Whoops, sorry, there, little mic problem. So much to that was terrific. All of that information. The I don't even know where to start, really. I guess one of the questions that came to my mind as you're talking about the follow-up education, the additional, I think it's 10 hours, 9 hours. Uh, do you, like, how frequently do you ask them? Do you say come once a week for the next 10 weeks, or I guess you might customize that as well, but how do you try to set up that program?
That's an excellent question, and that is where we find a lot more of our success also, because a lot of your corporate programs will set them up so they stack all those hours because they know they have 10 billable hours and they want to get them billed out. For us, we don't like to do a class more often than every 2 weeks because we want the patient to learn something and we want them to go apply it. And then they'll come back with questions about how they tried to do that in their life. Sometimes we'll do it once a month with them, depending on their education level, because we want them to go learn how to try to count their carbs, want them to learn how to add fiber to get a different net carb, what they're going to eat. And again, it goes back to my original statement on the appointment-based model. The pharmacies who say I can't find profit in this is because they're just trying to catch patients whenever, and there's really no organization around it. But if they will isolate out the time and just say, hey, we're going to do class every other Friday at 2 p.m., and we want you to come when you can, and we realize you're going to miss sometimes. What is key is having your curriculum set up so that they won't see a repeat class, even if they miss a class. And I'm very excited about the new standards because on the old standards, we had to kind of stay inside this curriculum on the 7 self-care behaviors, and we're still focusing on those behaviors, but ADCES has made it very clear that they don't want you to get stuck in a curriculum. They really want you to go through the needs of the patient and to teach them where they're struggling the most. And so to your question, they can come in at any time. We've got a couple of different quizzes we have them fill out whenever we go through that first one-on-one education appointment. So when they walk in and we pull their chart is labeled to show what they're struggling with the most, and we can make sure we focus on that in the class. A lot of what they want to, this is really against pharmacists' way of thinking, but they want peer-to-peer learning a lot, which just involves having a conversation with each other. And a lot of pharmacists think I need to have a big fancy PowerPoint, I need to have a microphone, I need to have a big presentation ready to go. It's really not. It's just, so Thea, you were having trouble, trying to find a bread that didn't have 120 carbs a slice. Did you have any luck? And she says, oh my gosh, did you know that Brahms has this, low carb bread? They put a bunch of fiber in there. And then Kathy says, oh really? How many grams does it have? Because I found one at Walmart and it had this many grams. And then they share with each other things that they've tried. Our last class, there was a big rave over tortillas. There's a lot of different types of low-carb tortillas out there, and all they've done is add a ton of fiber to the tortilla. And they also have these egg white wraps that don't have any carbs in them. They're egg whites and cauliflower. And people are talking about, well, where did you buy that at? Well, how did you use that? And then we can use that in examples. So pharmacists are great at having conversations with people, and that's what this class is. They can pop in and pop out, and we can ask them where they're struggling, and that's where you really get the success.
Yeah, that's great stuff. I think that when you get those conversations going with people telling other people what's been working for them, you just get that openness and a free-flowing conversation. And people trust each other too. They like to hear the successes of the people that they're in this program with. So that's terrific. One of the things that I also was thinking about, you talked about starting with your own patients. That makes sense. But to grow it, I guess you really do need, or do you need, I guess, to get out to collaborating with physicians, and where do you see that fitting into this whole program?
Yeah, if you take good care of people, you're going to grow. I'll tell you that. And So patients get those 10 initial hours. From the time you do that first hour, you have 1 year to get the 10 hours done. But then they get 2 hours every year after that as follow-up education. And so there's quite a book of business you can build out of your own patients. But part of the accreditation standards is keeping the communication loop closed. And so when the patient gets referred and you see them, you send the communication to the doctor that says, we've seen your patient. Here's what we see we can focus on the most. Here's what we plan to focus on. Tell us if you want to adjust the steering at all. And then after they finish education, they get another communication, which really it's required. But I teach all of my coaching clients, that's your opportunity to brag and say, Brad came to me with an A1C of 14, and he left my program at 6.8. And it's awesome. And here's what we did and how we did it. And so the physicians, they're getting rated on quality metrics right now, just like pharmacy has been for several years. And that's why they're all calling Thea to help them, because they need help with those quality metrics. And Kathy and I have had some very interesting conversations with some high-level surgeons about how to affect their quality rates, because pharmacists have those relationships with their people. And so physicians need those quality rating help. And so they will call you and they will figure out how to refer people to you that are not your current patients. It's quite interesting in our area. Kathy and I are about 20 minutes from each other. We're good friends and try to have lunch together once in a while. We're not too busy, but we've got a very powerful Part C insurance company in our area where 2 of our largest hospitals own that insurance company. And they like to pay themselves. They like to keep everybody inside their own network. And some physicians in my area who work for them, they actually became so disgruntled because our diabetes education program had much better results than the program that they owned and operated themselves, that we ended up on a Medicare fraud, waste, and abuse call with them. I didn't know what I was walking into. The doctor asked if I could hop on a brainstorming call, and I hop on, and I've got Medicare on the phone about fraud, waste, and abuse, about how this Part C program is forcing everyone into an in-network provider. And guess what? AADE had just done their annual status report, and all their A1Cs had went up. And so this physician says, I know somebody whose A1Cs go down. Let's get them on the phone and see what's different. And so guess what? I got in the network, and I wasn't even fighting for that, So if you take good care of people, just like with anything else, you're going to grow.
Sure. Well, I know we could stay on this topic and we could be talking to you all day, Travis, but we do need to move on a little bit, so we don't take too much time here. Something that really I think ties in, hand in hand here. Let's move to weight loss, Kathy, and I think this is your area of expertise. And before we even do that, Thea or Kathy, do you have anything to add to what Travis was talking about, or shall we move along to weight loss? Let's do it. Kathy, you want to start?
Yeah. Weight loss is an interesting thing that I happened on. I have a personal history of being morbidly obese most of my life. So I've done a deep dive clinically in my own study. So I was 100 pounds at 5 years old, 200 pounds at 10 years old, and 275 when I graduated high school. And I had a 350-pound grandfather in the Great Depression. Okay. So I've had my personal study of that clinical initiative, which is always for all of us a unique thing, because everything you learn is through your own eyes, right? But I think what's interesting, the critical piece for me that had me go into this clinical approach was actually a diabetes training I did. So about every decade of my career, I've gone and done a complete weekend of diabetes just to make sure I was up to snuff. And I remember about a decade ago being at one in Wichita, and the person who actually taught it made one comment that changed the course of my career. And she said, we know that diabetes takes 15 years to happen. And the research by Tabak, T-A-B-A-K, was very clear that in the progression of diabetes, there is such an adjustment in the body over 15 years prior to the first elevation of blood sugar. And I said to myself, why in the heck aren't we helping patients at year 2? Well, it's often because we are not interpreting these clinical signs and symptoms as part of the progression. We are, and especially one of the first symptoms is weight, because as the insulin increases to moderate the sugar that's within the bloodstream, insulin drives weight deposition. And so we often think that weight is causing diabetes, and I actually think, based on what I read in these studies, it's the diabetes causing the weight. It's the metabolic dysfunction that is actually causing the weight. So I thought to myself, I want to help people earlier in the progression. I don't want to wait till you're 16 when we've already got severe cardiovascular damage that's in place by the time the diagnosis happens. And so that set the tone for me to think about this. And I've been AADE accredited probably a decade ago. I mean, I've done a lot of that. I had a hard time getting people to engage. Plus, I had doctors who were incentivized to send patients other places. So I've dealt with all that Travis and I are painfully aware of. He's just nicer about it, or either that or I'm just older and crotchetier about dealing with it. So I was looking for, about 8 years, I told my staff and I asked them, how do you be a pharmacy and not fill prescriptions? Because that was the paradox that I saw that we were in. We were in a broken business model, and I don't have to be a very good business person to know that if you don't have control over your margin, you don't have control over your business, right? And we had given up control, however it happened, of our margin. And I didn't want to do that. And I didn't want my patients to need more medicines. I think we're often so focused on the tools that we forget to ask what the problem is. And the problem is, why are we so sick? Not why are we not taking 25 medications cheaply, right? That's not the problem. That seems to be the problem we're all focused on as far as the industry. But the better question is, why are we so sick? And what can we do to delay the onset or prevent the onset of disease? So those are the questions I started asking. And I've tried to make more money. To be honest, I needed to find a way to utilize what I have to create more margin. And to be honest, weight loss is a marketing initiative. What I give is lifestyle medicine. What I give is foundational health. I help people with the foundations of their physiologic function, right? Just so happens as a pharmacist, we're pretty trained in chemistry, right? So I just stopped looking at the pharmaceutical chemistry, and I started looking at food pharmacology, and the hard one is stress pharmacology, okay? And I created Dr. Kathy Weight Loss. And Dr. Kathy Weight Loss is a marketing initiative that is a 12-week health coaching program that walks people through a therapeutic, personalized clinical initiative. And I tell them it's not what I know that matters. It's not even what they know that matters. It's what they can routinely do that matters. And that's where outcomes occur. And so I tell them we are going to discover what it is for your body. What does it need to create the health you want, to live the life you want? Now, as I coached that over the last 6 years and 300 plus patients, there's certain challenges that have presented obstacles, which have presented opportunities for me to help them with, some of which is food. So I started in the pharmacy getting people to cook again, right? I saw some science that struck me, and it said whether or not you had a lot of money was not a determinant of health, whether or not you cooked was. And so you could be really wealthy and not cook and be sick, right? So I decided, well, I'm going to help people cook. Started in pharmacy cooking demos. I've got a brand of salts and spices that are getting ready to come out that I'm going to wholesale to pharmacy. It's called Dr. Kathy Nourish. And it's a way to provide the pharmacist with the opportunity to discuss the power of food and support patients with the power of food in having a biochemistry that creates health, right? And so all those things are solutions utilizing our unique and incredibly valuable skill set as the chemistry expert in helping patients not be sick, right? And I think patients want that. I think our grandchildren deserve it. And so that's what has me here. That's what has me pushing. And I'm pretty busy every day supporting. And I love what Travis said. Empathy will get you a lot farther than competency, right? And I think clinical pharmacists, community pharmacists in particular, because we're in the community still, are perfectly suited to be the stand for health in our community, not just disease management, but actually the prevention and the prevention of disease and acquisition of health and function. And they will pay for it.
And they will, because weight loss is a multi-billion-dollar business, right? And they're going to just about everybody but the pharmacist to get this information. So how do you get started? How do you tell pharmacists to get started? Because this can be a tricky conversation, right? You can't say, hey, I see you're 120 pounds overweight. You need to talk to me. That probably doesn't work very well. So how do you get started?
So I've been yelled at by my peers in pharmacy for the last 5 years to teach that or to help the industry do that. And I definitely am doing that. But there's a level of responsibility I have because you said it, lots of people are doing weight loss and lots of people are hurting people with weight loss. Okay.
Yeah.
So there is an integrity that I feel is critical in that relationship to support people. My first initiative was to create within CPA a 7.5-hour continuing education course called Creating Health, pharmacist-led lifestyle and weight management. And it really lays out over that class the critical pieces clinically of foundational health, right? What are the pieces that the pharmacist has to be aware of that are challenges to the patient's physiology and the approach? So I would really encourage people to look at that continuing education. I'll be teaching it in Las Vegas, Cardinal, and I'll be teaching it at Kansas City, and it is available online. So weight is a symptom. Weight is a symptom, okay? If somebody came into you with 104 temperature, you would not shame them, nor would you chastise them for having 104 temperature. When you have somebody who weighs 120 pounds overweight, I am marvel at the human species ability to survive. And I see that as an incredible, it's an incredible situation that the body is having to adapt to such that weight gain is there. It's not that trust me, it's not that they're eating too much. It's that they're not nourished at the cell, and their cells, in my opinion, are incredibly starved for the chemistry their body needs to function. And that because the cell is starved of what we need, the body will tell it to go eat, right? And our ancestors, when they received that message, they grabbed the leaf that didn't run away from them right next to them, right? We grab the donut that is right next to them, right? Which perpetuates the metabolic dysfunction and perpetuates the starvation of the cellular mechanisms, okay? So when I see 120 pounds, I have an incredible amount of compassion and I applaud them because their body has survived, right? I actually think we are experiencing as a species an environmental shift that is similar to what the dinosaurs experienced. We have had an environmental shift that our bodies are adapting to or not, okay? And it is profoundly, when you start having these conversations and you start acknowledging the powerful chemistry that their body has done to keep them alive, and they see it, and they've had no help, and they're starved, and you start fixing those things, light bulbs go off. And what I'm most proud of, I've got people still doing it 5 to 6 years later and maintaining that weight or losing more. Having A1Cs go from 13 and a half to 6.5 in 12 weeks. I tell this one story. I had a gentleman who was November of 19, he had 11.9 A1C, and by February he was 6.5, and by March he was 5.5, and I never met him. His wife did my program, okay? So we cleaned up the environment. We didn't put him on a diet. We just cleaned up the culture, the fishbowl that which they live, and then their bodies actually got nourished and their physiology skyrocketed. And one other thing I will say, I've had a lot of people talking about longevity and that what I do is a longevity, or I should market longevity. And I said, I don't think people want longevity. I think what they want is vitality. Okay. They want to be vital, and vitality is correlate to function. It's correlate to being able to participate in life. And the way you participate in life is to have a level of function where you can.
Right.
Health is function. And so what people want is to function well for as long as they can. And I think that's the missing piece, is that we're asking the wrong question. Not what medicine do they need? Why do they need this medicine is a much better question. And if we can help them ask that and them answer that, then you get behavior change in such a way that is not difficult and it is sustained.
Absolutely. So the just going back to the original question though, how do you approach it? I mean, you now have a program, you now have, and you have a marketing plan for it. But when you got started, and when one of these pharmacies isn't doing this today, it's one thing to talk to them about their they're diabetic, and that's an easy conversation to start. Weight loss isn't necessarily an easy conversation to start, even though people are spending billions of dollars. But a lot of these people are spending the billions of dollars so that nobody knows that they're dealing with this. They're going online and they're seeing all these advertisements for this pill you can take, and it's going to say you're going to lose 20 pounds in a week, and so it's not embarrassing for them to deal with it in that situation. How do you recommend to a pharmacy to get started with the conversation with somebody they know has a problem?
Well, I had a patient say, I never thought of a pharmacy to come in and doing this, but it makes so much sense. So first you have to let patients know that you can help them with it. I think marketing is a huge issue for medical professionals in general, but pharmacy in particular. We're a very humble group, and we kind of think people know what we do, right? And the reality is they don't. In most of the last 2 decades, our image in the consumer's mind is been hijacked, really. I mean, the people on this call are a little bit different because we are working on marketing and crafting that conversation in our consumer's mind. But as an industry, pharmacy is off the radar for most patients, or if it is, they're mad about it, right? So us creating a conversation with patients is marketing. So whether that's a ticket, or whether that's a seminar, or whether that's a one-on-one conversation at the register when we're doing point of sale and we're consulting. And let me tell you, these medications are making us fat. The medications are absolutely hijacking metabolic processes, and nobody's helping with that. So if I have a patient that's on PPI and I'm dispensing that to them, I'm going to ask them, have you gained weight since you've been on this particular medication? And that's going to open a conversation, and I may be able to help them with that. Okay. So, the greatest advantage for a pharmacist is that prescription, not because we've got it. It's because we know what it's about. We know why they're on it. We know how they got there. We know the clinical impact, and we probably know how to get them off of it. If given tasks for that, we could probably do that better than about anybody. So I think the conversations, first you have to develop a relationship, be it through marketing or be it through one-on-one. And then you just, with empathy, ask them about it and then offer a solution, right? And that's really what I think is missing in pharmacy, is the offering of a solution, right? Is crafting new tools to sell, products to sell that actually solve different products, and then getting your patients to see you as somebody who solves their problems. I don't know if that helps or not, but it is a marketing initiative that ultimately has to be embraced.
Sure.
And I want to stop you there and ask a question, because I have seen this as, you said a very key statement there, Dr. Kathy, where you said the medications are making people fat, right? So the problem we've ran into is some of the medications that have a very marginal improvement to the patient's health, or are actually not benefiting the patient. There's been some kind of a quality metric tied to the physician for them to be on that medication. So in that instance, we have gotten people off of all their diabetic meds using, carb ratios basically. And then they go to the doctor and one of them is my delivery driver for my pharmacy. She went through our program. She lost 43 pounds. We got her off every diabetic med that she was taking. And she goes to the doctor. The doctor says, oh my gosh, you get back on your medicine right now. You need to eat 45 grams of carbs at every meal. It's not 60. You need to be eating 3 meals a day, 15 grams of carbs. And so she is someone that I have even more of a relationship with beyond a patient. She's my delivery driver and has worked for me for many years. And, she was greatly affected by that doctor, and then the other piece of that is, I was going to ask you to reflect on that for us real quick, because I know that you're a genius at dealing with that kind of thing. The other one that we run into problems with, sometimes lifestyle change is hard, and I'd rather just take a pill. So how do you approach those patients?
Well, I fundamentally don't think people want to be sick or want to be fat. I don't think they often are clear about the costs of that conversation. What does it cost them to do this and take this? There's always a cost, right? It may be a metabolic cost. It may be an energy cost. It might be a functional cost. And often, it's their choice. What I tend to do is have them really tease out, one, what do they want? And two, is that approach going to get them there clinically, right? It might get them to 60 without a heart attack, but it probably won't get them to 70 and be able to go to their grandchildren's. I don't know. We'd have a lot of research about eating 10 servings of vegetables a day. It's hard to do, but the research is there. So then it's really getting them to be aware of that cost. And going back to what you first said about the metrics, I think that goes back to what I was saying, that we have a system that's focused on the tools, not the problem. We're not asking the right question. And I have this conversation with my senators and my congressionals when I go to try to get all the junk done in Washington that we need done. And I say, after we get all this insurance stuff figured out, we got to start asking a better question. Why do we need so many drugs? Why do we need so much health care? Okay. And you look at what happened over the last pandemic. Why is our life expectancy worse than anybody else in the developed world, right? Those are the kind of questions that they're not because we're not taking enough drugs, really. There's some environmental and cultural issues that are tough, but we need to be asking them. And the incentives are wrong. The patients know it.
One of the things that struck me as you were having this, explaining some of these things, I think every single opportunity, every single time that a pharmacist interacts with a patient, it's an opportunity. And it's an opportunity to educate. And it's an opportunity to learn what's important to the patient by asking the right questions. And I think that's fundamentally a change, because I hear so many pharmacists complain about counseling, having to do patient counseling, but the only thing that they take that moment and say, do you have any questions on how to take this medication? As opposed to taking the opportunity to really sit down and spend a few minutes, learn something about the patient, and by asking the right questions, and then maybe being able to say something, if I could help you, if we could work together, would you eventually like to come off this medication? Possibly. Could we work together on a path that might help do that, as an opportunity to do something like that? And I think it's an important point for every pharmacist to be thinking about. Every single time you speak with a patient, it's an opportunity.
I'm glad you said that, Brad. I want to add one thing. Are you a transactional pharmacist, or are you a relational pharmacist?
There you go.
We have a profession that has been hijacked into the transaction. It didn't used to be that way. I mean, I never forget talking to a pharmacist of the 30s and 40s. He said, we fed our family of 5, sent them all to college on 20 scripts a day. Okay. So it's because they had a relationship. And so we have pharmacies set up for transactions, not for relationships. And so I really think that's a distinction that can make a difference in our profession if we can embrace the relational part of a business model of relation.
Yeah, absolutely. And I mean, we talk about that just in business in general here at RMS. We want every interaction to be relational, not transactional. And sometimes they have to be transactional, but whenever possible, you want to try to make it relational. And I think that's how you become successful in business. And I think that's, why we've been able to do what we've done for 23 years. And we're the only company left that does point of sale for pharmacy. And the reason is because we really have, customers that are loyal to us because the relationship we build with them. So, we're going way over, and if you have some additional time, I'd like to continue because this is just such great stuff. So, we'll keep moving it along, but overall, the clinical workflow. Thea, can you start here and give us some tips and advice on managing, one or multiple clinical services, how to successfully integrate chronic care management, into into pharmacy business models and things of that nature?
Sure, yeah. I think chronic care management, much like the diabetes education and training that Travis was talking about, is something that can be integrated into the system of your day-to-day operation. It's the conversations that you're already having with Brad when he comes into the pharmacy. Those transactions, if structured correctly by the education needed for what the programs need from a discussion standpoint, you can be capturing the time that you spend making the relationships that you were just talking about very important and learning about the patient. If you take the time to stop being the transaction and start being a listener, and be able to transfer the inspiration of what these people need, they don't even know what they need. The health literacy in the country is 12%. Like, they're not going understand and know what they even need to know about their medications, let alone any healthcare related interactions. So when you start having the conversations, yes, you came in and picked up your metformin, but I wanted to talk to you about all other medications that you have. Are you sure you are taking this one? Because if you were taking this one, this wouldn't be happening to you that you just told me about. And listening, those listening skills that we're all taught. And that's why I think that customers come to us at our retail pharmacy counters, is to have the conversations where someone is listening. Outside of the big box stores, I think there's a lot of that going on that we can really reap the benefit of what that conversation is. First, because we're building the relationship. Second, because we're spending time with the patients. And third, we can bill for our time. So really implementing a chronic care management program into a retail pharmacy can be very lucrative because you're already having the conversations. And after 2.5 years of doing just this, yes, I'm not placed in the pharmacy, but I have plenty of pharmacy experience of independent pharmacy and know that these conversations that I have with these patients on a monthly basis, when I call them up and say, hi, Mrs. Smith, I'm here to, I'm calling to go over your chronic plan with you. How's everything going? That's the same conversation that I had at my retail pharmacy counter. And that's the piece that people don't think that there's no money behind it. It's because we've never looked at it. We've never transferred the inspiration of the sell of what we could do, because we all know, put the stuff in the bottle, run the transaction, and give it to the patient because that's what the patient needs. But much like Kathy was saying, it's about wellness. It's not about we need to polypharmacy everyone. That's not the intent of medicine. So it's it wasn't the original intent of medicine. Let's go there. Maybe some other people might have something to say about that. But, when we start having the transaction go away and build the relationship that they need, and more times than not want, the patients want these relationships with us. And so when you start really doing that and building that into your workflow, that 10-minute consultation that you just had about their new prescription turns into 10 billable minutes for that month. And when you start accumulating those, that hour goes so fast when Mrs. Smith comes in from 3 different appointments this month. And I've talked to her every time. So this is huge when you think about the time you're already spending with your patients and moving it forward to actually what you could do with it from a chronic condition standpoint and what the codes you could bill and get reimbursed for. It's not changing what you're doing. It's just thinking about it differently, because you're so in dispensing the medication that you forget that you're even doing most of these conversations, because there's another prescription waiting for you back there just to go do, and you don't even think that those things can add up. And they really do very quickly when you have the patients coming in and talking to you. You guys know the person that comes in every week, like if you had them on a plan where you could, not monetize that relationship, but get paid for the service that you're already offering because you're having that conversation anyways. So how can you get that in there? Chronic care management is a great way to do that, with building that into the workflow that you're already doing. It's not different. It may be a little bit more time, or on your downtime, you may have to call Mrs. Smith and talk to her a little bit longer. But for the most part, in independent retail pharmacy, I've found that it's not a hard stretch to really incorporate chronic care management into the conversations that you're already having.
So is that different, when you're making, how is that different than remote patient monitoring?
Remote patient monitoring is about the devices, right? I have patients on remote devices, and that's really helpful because you're actually getting to see what their numbers are and how to move the numbers, right? With the medications or wellness and all of the different avenues that you could take, lifestyle modifications and wellness and weight loss and all of the things that are really mattering for the medication and the numbers. But chronic care management looks at the whole picture. So okay. Remote patient monitoring is really driven by the device that's being captured, the information being captured. But when you pair those up, and marry them together of, I'm dealing with Mrs. Smith's chronic conditions, and her one chronic condition is high blood pressure. Well, I'm going to get her on a blood pressure machine, see how high it really is. what is this doing? And has her metabolism changed over the years and no one's adjusted her medications, and what that really looks like for the patient? Could a polypharmacy be going on? Absolutely. Can we reduce her medication load? Maybe, because she's watching her sodium now and she's taking fiber and she's drinking lots of water and doing all of the things that really help her with her blood pressure, that she may not even need that blood pressure medication anymore. And I've seen it both ways, where we need to get more medicine on board, better lifestyle skills, and then, and then hypotension for a lot of patients as we're aging. So I think those two things, chronic care management and remote patient monitoring, kind of marry together in my world, because it augments the information that you're gathering, right? You're gathering more information, you're building more of a relationship with the patient, checking in, caring for the patient, because you're calling and talking to them, or that you're talking to them about it in your retail pharmacy at the counter, that they're already coming in and seeing you anyways. So I think those programs really marry nicely, even with Travis's, the diabetes education. I think these programs really are not a far stretch for what you're already doing. It's just a way to be able to be more than just a dispensary.
One of the things that comes to mind as you've been talking about, all three of you have been talking about this to me is, and I don't know, I'd be interested to hear if you've made changes to the front end of your business, but to me, being a guy who focuses in the front end, being a point of sale company, to me, these are all great opportunities to change what I have in my front end, because, the reality is, I don't know about everybody, but I usually buy shampoo at either Costco or the grocery store, Crest toothpaste at, either Costco or the grocery store, because I'm in the grocery store every week. And so that's where I'm just trained. OTC HBA products, that's where I get them. I don't go to the pharmacy. I don't go, to buy that stuff. But to me, if you're trying to lose weight, or you're diabetic, or you're taking any medication at all, there's a likelihood that it's depleting some supplement or vitamin in your body. To me, I would be changing the front end mix of my store to really tie into the things I'm teaching my patients. Is that something that you do?
I'll speak to that just a little bit. I've been in this position for 20 years in my store, and my front end has changed pretty consistently. I think the last big thing I did is, one, I sat my dispensing pharmacist down into a desk in the workflow and made a semi-private office for her right next to the dispensing. So that's one thing. I also started creating my front end as a lifestyle support. I sell cast iron, the best cast iron pans that are made. Why? Because nonstick is killing us. And we have a lot of evidence to that. And many of us are low in iron. So I'm like, check. That's two big things. And then, like I said, I've got food and stuff to cook and support that initiative. But I also have a private label of pharmaceutical grade nutraceuticals that I know work. And so when I make a recommendation, I have a consistency in that product, and I have a confidence in knowing that if it doesn't work, then it's my recommendation, not the product. And so that's been a critical piece, and patients love it and they get results from it. So that's been financially a big piece. But yeah, the front end is our opportunity to build. And I've got my front end on wheels, so I can move them, so I can have 30 people in my front and have classes, or 10 people. And I can actually, and I did a seminar this weekend. And so, yeah, that front end is critical and needs to be way more flexible, and don't sell things that you don't make money on. The other piece is, we've got to really, as a profession, look at when we're going to stop losing money on dispensing. When are we going to stop accepting below costs on dispensing? There's other ways to make money. It's a hit to our identity if we're not dispensing, but I'm not a good enough businessman to routinely lose money and stay in business. So my front end is a critical piece.
Sure. And that's a reminder. I mean, I did a CE piece for NCPA on the front end part of your business. And one of the stats that we found was, the average pharmacy front end turns is 2.4, which is torrid, just terrible turn rates. You can do so much better. And I think pharmacies are still carrying too many things that really don't tie into what their profession, what the pharmacy profession is doing today. You need, I'm not going to tell anybody what they should be carrying, because everybody needs to be looking at their own business and their own, what your practice is doing and what it's focusing on, but you need to be carrying the appropriate things for that. So if you're focusing on weight loss or smoking cessation, you probably shouldn't be carrying cigarettes and giant aisle of ice cream and snacks and things of that nature. So anyway, but every business has to monitor that. I just think that today so many pharmacies say, well, 95% of my business is pharmacy. I don't care about the front end. And I think that's just a major, major mistake. Well, listen, we have gone way over, which is wonderful. I don't care. I mean, I would like to keep going, but let's have we didn't cover a few areas. We can't get to everything, and maybe we can have you back for part 2 in a few months. But how about just, would anybody like to parting shot, last thought that you think we absolutely need to know this?
I think from my perspective that the pharmacy owners and the pharmacists in the community retail pharmacy settings, I think remembering that we're not selling something, we're transferring the inspiration to our patients and to those physicians. We all know what the DIR fees are. We all know what those quality measures can do. We're in this together, and it's going to affect the physicians as much as it is the pharmacy owners today. And that is the transfer of inspiration that really can build these programs now in those pharmacies. If you've ever given a thought, now is the time to go with that transfer of inspiration. As you know, they're all scrambling. Physicians and pharmacy owners are scrambling to get on board with these programs, and there is so much support out there to get moving forward. So do it now.
Great, Thea. Thank you. Travis or
I'll
Kathy?
just say, I'll let your patients need you to be there. Okay, they really, really need you to be there. And no margin, no mission. You have to be profitable, and we have to find another way. We have to be willing to stop doing things that lose us money and start embracing and appropriately utilizing your unique skill set to provide value in the marketplace. And trust me, your patients need you to help them be well. Your grandchildren, your great-grandchildren that aren't even thought of need you to help create a world where they can be well. They need it now, and they can do it. You can do it.
For me, I need to be a pharmacy owner for many more years because I have a 7-year-old child. So I need you to be successful too, because I can't do it alone. I mean, I have Caremark reports saying that I have 100% compliance for my diabetics, and I have 100% compliance on my statins. I don't on my ARBs and my ACEs because of all the recalls with losartan, but, I can't save the independent pharmacy world by myself, even if my stores are doing everything perfectly. So I need you to call Thea. I need you to call Kathy. I need you to call me, and let us knowledge share with you to show you how you can put this into your model. For me, our healthcare system is broken, and all three of us have talked about different ways that is. The pharmacist is the key to that locked door, because we've said for a long time we're the most successful person on the healthcare team. Well, that is one thing we've really seen with things like diabetes education. We can really affect your health because we know exactly what's going home in your bag to go into your mouth later that day. And we're the funnel where all the other providers come to. We're getting the stuff from the heart doctor and the lung doctor and the kidney doctor, and it all comes through us. So for me, I see the future of our healthcare problems being solved by the pharmacist being the extender of primary care. And the other opportunity that is out there that we didn't talk about a whole lot here, but our pharmacy schools are putting out clinical geniuses who don't know how to run pharmacies. So if you don't want to do this clinical stuff, they're being brainwashed. They need to go do residency and go work for a hospital. But instead, hire one of them to come run these programs for you. And I'm a little bit different than Thea and Kathy. I'm not going to say give up your dispensing, because I want to dispense and make money there too. But I want to also pair that dispensing with healthy chronic disease state management so that I have a healthy patient, and I'm ultimately the gatekeeper because I know what's going home with them in that bag. And that's where our future lies. So if you don't get involved, then DIR fees and PBMs are going to kill us. But if you will get involved, you can have a lot more control of your destiny. And my 7-year-old's destiny, no pressure or anything, if you'll get off of your high horse and just start thinking about how to take better care of your patients. So thanks for your time today. We appreciate everyone coming and joining today.
Yeah, and I appreciate all three of you. And I just want to add to that, Travis, invest in your future. Invest in your future. Everybody's heard it takes money to make money. And that was such a great example because, in fact, I have a very important person in my life who's in pharmacy school right now, and he's been talking about the clinical approach. We've been chatting about some of the climb stuff, and it's these people are out there, and they are excited about it. So investment, because, and believe you, all three of you, and so many others that are in our panels, there's money here. You can make money. Invest a little money to make some money and to make your patients better. Well, thank you, all three of you. It's been a great pleasure. I would love to have you back. I know there's a lot more that we can cover because there's a lot of questions that I never got to. But thank you so much for your time. Thank you for what you're doing for patients, for independent pharmacy, and I really, for all of our listeners, I appreciate your time very much.
Thank you, guys.
Thank you so much.
We'll be right back, folks.